And you're live. All right, good morning. It is January 19th. This is Senate Health and Welfare. And this morning, we're welcoming the Chief Executive Officer of of United Way in the northwest part of Vermont. So, Jesse, thanks for coming in. Before you introduce yourself, I'm going to have the committee introduce themselves. And we'll start with Senator Hardy.
Good morning. I'm Senator Ruth Hardy from the Addison District.
I'm Senator Terry Williams from the Rutland District.
Ginny Lyons, Chittenden Southeast.
Dave Weeks, Rutland.
Martine LaRocque, Ulick, Burlington.
Welcome.
Thank you.
So why don't you introduce yourself and tell us why you're here today?
Great. Well, I appreciate the time and good morning. And it is a busy Friday, and I appreciate you taking a bit of time. As mentioned, for the record, my name is Jesse Bridges. I'm the CEO of the United Way of Northwest Vermont, and I work in partnership with my United Way partners across the state. We have United Ways representing every county, every city and town across the state. I am connected to your committee's work on multiple fronts, certainly as a leader of an organization focusing on community and population health, and particularly the social determinants of health. I also, as a note, am the current chair of the board for the UVM Medical Center. So might be seeing you in other facets later in the year, in particular with the bill that you're working on next. So, and I know the early part of the session is filled with quick deadlines and lots of information coming at you from a variety of directions. I'm here today to simply offer our support and information. I'm not here to sit today to ask anything of you particularly, perhaps a welcome change. What is so unique about United Way is that we exist at the intersection of nonprofits and government and business and community. We get to see how everything and everyone is connected. And we partner, as I said, across all of Vermont's counties, cities, and towns. We cross urban, rural, big employers and small businesses, for-profit and not-for-profit, state and local government, minimum wage earners, and those more fortunate in their socioeconomic status. We exist at that intersection because we believe that is where change happens. As you're aware, the challenges we face in Vermont, from housing and food insecurity to flood recovery to increased mental health crises and substance misuse to our workforce challenges and any economic instability, all of these challenges are overlapping and interconnected. We are here to help every person in our community access the resources and the connections they need. And we do this by supporting a variety of local organizations, running our own programs, in a minute, engaging in advocacy and community education, and bringing people together from different sectors and walks of life. Today, my colleagues and I are in the card room providing information about our Working Bridges program. Working Bridges is a partnership between United Way and employers focused on giving employees the resources they need to gain, keep, and grow in stable employment. We do this by bringing human service support directly to the employee on site at the workplace. Our program has been around for 17 years now and has 29 employer partners in manufacturing, healthcare, nonprofits, and higher education across northern Vermont. Last year, we served over 3,000 employees, and thousands more had access to our services or got connected through a colleague or family member's use of our services. Access to resources and trusted relationships at work helps employees overcome life's challenges without having to miss work or leave their jobs. I'm speaking to you today to offer information we have gathered through this work about what keeps employees off the fiscal cliff, what resources work, and what systems need to change to help our neighbors achieve stability and thrive, to help Vermont employers retain a stable workforce, and to create healthier, more resilient communities. Our work with both employees and employers and local communities gives us unique insights that could be valuable to your committee and the rest of the legislature in the coming year. And we're eager to partner with Vermont legislators on solutions and to offer data, resources, and local voices to help inform your work. One such resource I brought for you today, and is of particular significance, I think, to your committee, is our mental health toolkit. This was created in partnership between our Working Bridges program and our mental health initiative. We have heard from employers how our mental health toolkit is both comprehensive and functional for businesses and organizations. Recently, a client sourcing this toolkit said the scripted language and data presented throughout the toolkit removes the guesswork on how to approach mental health wellness. We offer this for free for our community, and we are actively distributing it as much as possible. You now have a paper version, there's a digital as well. Shortly, we're going to have our 2023 network report to share throughout the Working Bridges Network, which will provide insight into the most pressing issues for working Vermonters. The issues should be of no surprise, such as access to affordable or any housing, food insecurity, childcare, healthcare, and more. Over the last few years, we've also seen a sharp increase in the need for connected and services around mental health care and substance misuse, treatment, recovery, and prevention. To address this, our staff has invested in mental health first aid training. We've also invested in becoming peer recovery coaches at the work sites so that we're able to support employees whatever crisis is happening for them at the time. We've also created in the past through our work with the Chittenden County Opiate Alliance and our program, Working Bridges program, a toolkit around employing people in substance use recovery. Coming out of the pandemic, we've seen a need to upskill our community to become protective factors for each other and through mental health first aid training. So not just for our staff and our resource coordinators, but for the community as a whole. We've doubled the number of mental health first aid trainers in the state just in the last year in order to bring this to more people. So I'd say today, if I was to choke at this table right now, does anybody in here know the Heimlich? Okay. You do behind me? Good, okay. Heart attack and stop breathing, anybody know CPR? Okay, good. Anybody here, any of you paramedics or EMTs? Right, and that's not the point, is it? Right?
Used to be.
Used to be. But the point is that's a community resource, right? It's community amplification. What does it do? It buys time. Buys time for the paramedics or the EMTs to arrive. Buys time to get to one of our exceptional local hospitals. That time is important. And it's not by accident that the number of people in I've made that comment at hundreds of businesses and community meetings across the state. Every time there's somebody there. Every time. They're not necessarily a trained professional. We need that same thing for mental health. We need the ability to be there for our neighbors, to become protective factors for each other. We would love to parachute in about 2,000 more mental health professionals into the state. We know we can't do that. First and foremost, there's nowhere for them to live. Secondly, training and the education has costs associated. So we need to become protective factors for each other. And so we are also, in addition to providing mental health first aid training across the state and partnering with our designated agencies to do that, I have offered to the speaker and Senator Pro Tem that we are willing to provide mental health first aid training for the legislators. Not least of which we forget that this is an employer. This is a place of business as well. You are employees. And so we want to help you become better protective factors for yourselves, for your constituents, for your neighbors. We firmly believe the power of our collective work, and thank you for your efforts in supporting the health of our community. Our team stands ready to offer connections, insights, data, conversations, and hope. Change happens when local people come together to focus on local solutions. But it's not just the change that happens at that marvelous intersection. It is hope and pride in what we all accomplish when we work together. As we dive deeper into this legislative session, let's choose to focus on and to grow what's working in our communities. Let's encourage our hopes rather than our fears. I look forward to working with you more in the months and years to come. Thank you.
Thank you. Jesse, thanks so much for coming in and giving us the information. If you have that in written testimony that we can put up online, it'd be great.
Yeah.
Good. Thank you.
Great. So, and I'll offer, we're in the card room, so I know you have a busy agenda.
I'm sure you'll get
Please.
some visits.
Please come on
That's
by.
good.
We have chocolate.
Oh, you'll definitely get visits.
So how long is the training for the mental health?
Mental health first aid training is an 8-hour training. We recommend doing it in 2 4-hour blocks. It's fairly intense. And so we also find that 8 hours of doing it is a long time. So breaking it up into like 2 consecutive 4-hour days has made it much more accessible for a variety of different employers. So and we do it with groups of employers too. So not just.
That would be a cool Health and Welfare Committee thing to do.
We'd be
Yeah,
happy
it would
to.
be great.
We would
Well,
love to do
I
that.
just will share with you that one of my daughters is a mental health counselor, and so when I'm with her, I get training all the time.
There you go.
She's great.
Excellent.
Yeah.
All right.
Yeah, they didn't turn your training out.
No.
That is the idea though, right? We
Yeah.
all become, if you can, it takes one person, one conversation to intervene, and prevent things like suicide. Just one trusted
Right.
person. So if we all step up, we all have a role to play as a community.
Right, we need to expand it the way we have the CPR issue.
Exactly,
Yeah, it's great.
exactly.
Yeah, thank you.
Good, thank you so much.
What, Senator Hardy has a quick question.
Oh,
Yeah.
no, actually, thank you very
Yes.
much. And my question was the same as Senator Weeks, but I did another health and welfare related thing that's in my email, just want to announce to the room. It's about the vaccination clinic today. And it's open to staff, legislators, and members of the public. So if you haven't yet gotten your COVID booster or your flu shot, second floor, room 33, you should go do it.
Good announcement. Okay, so we are going to move to S211, and I understand that there's a lot of interest in the bill. The bill is also very complex and for many folks difficult. But I will say that my interest in introducing the bill is to begin to get some clarity around where we are in our healthcare reform environment and how to clarify various roles for various organizations, including the Green Mountain Care Board, which is a critical regulatory entity in our state, and to make sure that the Green Mountain Care Board has what it needs in order to regulate appropriately. The other big piece for me in the bill is looking at alignment. We have private payers, we have public payers, and we have a system that we're putting in place for connections with community services. So it's going to become really important that we align administrative guidelines and administration overall, and also to ensure that we have equitable reimbursement across the board, regardless of who the practitioner is and whether it's a large hospital or whether it's an independent primary care doc. So we're beginning, there's a lot of discussion that we can have. Not everything in the bill appears to be directly associated with each of those things that I've identified. However, they are implicit, and I think that as we have testimony, we'll hear from different entities, different perspectives, and then our job is going to be to have to put all of those things together in the bill to move forward. So I have no preconception that the language that's in the bill is going to be what ends up in the bill. It could be completely different. I have, this bill for me is the beginning of a really critical conversation that should have been happening a while ago. So I think we take it on ourselves to look at the difficult, and this is difficult. That's all I'll say about it at this point. And I'm going to suggest that we have a lot of witnesses. I've just taken up too much time. And I'm going to ask us to ask questions of clarity and to save our comments on the bill until we get into a mode of discussion. Devin Green, you want to come up?
So we do have a PowerPoint. Do you want me to put it up on the
Sure.
screen? Or?
Yeah, that'd be great. I know that there are a number of folks out on Zoom who are joining us, so it's important that any testimony, anything we can do to share that would be great.
Oh God, I just, there's me right there on the screen. Okay.
Yeah. 211.
Yeah.
Okay, great. Thank you for having me here today. My name is Devin Green. I'm with the Vermont Association of Hospitals and Health Systems. We represent all of Vermont's hospitals, all of which are nonprofit. The other thing I want to point out is that we meet regularly with various aspects of the hospitals. So we do meet with the CEOs, but we also meet with emergency department directors, chief nursing officers, chief medical officers, HR, IT, chief financial officers, a lot of aspects of the hospital. So as healthcare issues come up, please look to us as a resource. I just want to start by setting the stage of Vermont's landscape for healthcare. It is a difficult, both physical and metaphorical landscape. According to the 2020 census, we are the most rural state in the nation, and that's defined as having the percentage of population in rural areas. So unlike places like Montana, where everyone's in one or two cities, Vermont is really spread out throughout the state. And so that does make delivering healthcare difficult, along with, mountains and snow and everything else. We're also one of the oldest states in the nation, and you'll see that that is really going to play into our ability to deliver healthcare. Putting our hospitals in context, I know that we've heard from various folks that we have too many hospitals. The fact that we have a lot of hospitals is a luxury. I just want to put out there, we have 14 hospitals. We have one psychiatric hospital, and we have one VA. That's who we represent. And our beds are lower than the national average. They're actually lower than a lot of other places that have a public health coverage system like Canada or places like that. And we're significantly lower than Washington, D.C., which is a similar size to the state of Vermont. Going back to the age piece, as you've probably seen, JFO put this out, but I just want to stress it for everyone. The fastest growing part of our population are those over 65, so the 65 to 79 age group. And we are really feeling this in our hospitals. In 2021, when we started collecting extensive data due to the COVID crisis, we saw 70 people in our hospitals statewide who were ready to be discharged. They didn't need hospital level care, but they didn't have a place to go to. Now 70 is unfortunate, that's a lot. There shouldn't be 70 people in the hospitals, they should be placed somewhere. Today, we see, as of Tuesday, 142 people waiting in the hospitals for placement. That's causing serious problems in our hospitals, as you'll see later. In addition to causing capacity problems in our hospital and patient throughput issues, I just want to put some of the aging and costs into context as well. If you look here on the left, you'll see that here are the states with the greater proportion of people who are older. And if you look on the right, you'll see the costs. And for a lot of those states, they do line up. Caring for older people, older populations is costly. And I do appreciate the move to primary care. We are highly committed to moving towards expanding primary care. We think it's the right thing to do. It's the ethical thing to do. It's better care. But it doesn't necessarily make costs or healthcare problems go away. I've heard the story of a patient at one hospital who's a logger. He's had a rough life. He got Blueprint primary care intervention. He probably would have died of a heart attack at age 50 or 55 or whatever. And here he is 20 years later, and he's had a good 20 years, but Now he has things like COPD or other serious health conditions that need care also. So in thinking about how we want to move forward, I want to make sure that we have the ability to care for the folks who will be sticking around with us longer due to our primary care expansion. I do want to touch on the hospital financial picture because this comes into play as we talk about healthcare reform. So 10 years ago, hospitals had a rosier financial picture. I think we had a little bit of padding. Going into the all-payer model, we could say, all right, we are committed to these concepts of moving from fee-for-service to value-based care. We want to do this. We'll figure out the details later. At this point, we just don't have that same opportunity to figure out the details later, which is why we're coming to you today. And so 9 out of our 14 hospitals have negative operating margins. And you'll just see over here again, with that aging population, this picture here with all the reds and grays and greens, this is a presentation that the Green Mountain Care Board hired a consultant to do, and the consultant found that, you know, the covering costs, all these red areas are costs that are not covered by Medicaid or Medicare, and even commercial at some points. And so as we age, as we get onto Medicare, those costs are likely to go up. It's going to put pressure on our commercial market.
If you have a question or clarification, go ahead.
Yeah, okay, thank
Yeah.
you. 60% of expenses are labor. Does that include administrators and the whole?
I'll have to go back and check. I'm not sure if we calculate the administrative costs. We do have, the Green Mountain Care Board does collect that salary information for CEOs and management and clinical leaders.
Okay, thank you.
But I will just say that care is expensive. And I would, the 60% is not the CEOs. If you look at other care industries like childcare and like long-term care, it is generally very, very expensive. And then it also feels like those folks are not getting paid enough either. And I think the same dynamic is happening here. I do think our healthcare workers make the median, which is where we want to be as we look at healthcare costs, but it is very expensive. The care industries are very expensive. So I want to talk a little bit. I had a meeting last Friday with our emergency department directors, and it was very sobering. And as I was doing this, I went back to a slide that I did last year for House Healthcare Committee that was just a snapshot of our healthcare system and how we were in crisis at that point in time. So in our emergency departments, we had 30 people needing mental health care boarding in the EDs. Half of them were there for longer than 24 hours. We had 25 patients boarding there for medical surgical beds, so just medical patients. We've been hearing a lot about people who are having heart issues or other really acute issues waiting for much longer than they have in the past. And we saw an increase in workplace violence as well. We also saw our medical surgical beds, our ICUs were very full. There were 3 to 6 ICU beds available statewide. And we saw a lot of patients that were waiting for discharge. So similar to our 142 that I just talked about for this week, 137. And that was taking up a significant percentage of hospital capacity, which again, makes it very difficult for patients to get in and out of the hospitals. They can't move from the emergency department up to where they need to be because someone is in that bed already. And when I went back to look, it was a very similar picture, which was really sobering. I think where our emergency department directors had a lot of frustration was not like, it is still a very similar picture, but the difference is the sort of feeling of emergency or feeling that we need to do something about this is not there. So we were talking about how a couple years ago, if there were only 5 ICU beds across the state, we would hear from AHS and they would say you have to open up more ICU beds. We are one car crash away from not being able to handle an emergency, so get some more ICU beds open. And as one emergency department director put it, now we have 6 ICU beds across the state and it's just another Tuesday. And we're just having to deal with it and figure it out. And they're feeling really isolated and like the general public doesn't understand the day-to-day pressure that they're undergoing in terms of the capacity of the healthcare system. So I will say there's a bright spot in the mental health space. Last year it was 30 people waiting. Now it's 15 to 25 people. We think DMH has done a really great job of implementing some new programs. I always mess up on the name, but the crisis teams that go out. Mobile crisis units, thank you.
Yeah.
The crisis teams that go out, the alternatives to emergency departments, the general, they have a medical director who used to be an emergency department doctor who's just fabulous. And so we've really appreciated the work that they've done there. But, clearly it's still unacceptable to have people waiting in our emergency departments for care. We have 30 patients waiting in our IDs for a medical surgical bed. That's up from the numbers last year. So again, that's another issue. Our largest hospital has 0 medical surgical beds, which I've seen play out. My friend's mom had to wait a couple days to get a bed. So that clearly is a problem in the system. And we've seen that with both our tertiary hospitals as well as with tertiary hospitals in Albany or other parts of the state. We've heard about Albany having, you can send an ambulance to Albany, but that person will have to wait in the ambulance for hours and hours and hours for Albany to take them because they're so backed up. This week, as I mentioned, 142 patients are waiting for discharge. They don't have placements. And this directly impacts the cost, as we see in the system too. So not only the cost of people not being able to get care, but hospitals are, we may have a low Medicare rate, but that's because Medicare doesn't pay for keeping a person in a hospital who doesn't need to be in a hospital. So hospitals are really having to both absorb those costs and pass on those costs of caring for patients who don't need to be there. And so as that's where we are. Things are really tough in terms of getting patients through, getting the right care, the financial situation, and we are embarking on a big effort here in Vermont. So you've heard a lot about Act 167, hospital transformation, that is moving along. In addition to that, you've also heard about the AHEAD model, which includes global hospital budgets. And we are on a really tight timeline for that in terms of healthcare reform speak. I know here, 2 days feels like you can get a lot done in 2 days because we have to move quickly, but for moving the healthcare system along, this is incredibly tight. A lot of our hospitals are doing their 2025 budgets right now, and this is happening in 2026. So we are really looking for a more clearly defined structure of how we're going to approach this in order for us to determine whether or not global hospital budgets will work for hospitals. We need to know what the regulatory structure is going to look like. So as we move along, we would just say that's why we're really interested in having this conversation. So as you'll see on this timeline, the application is in March. We haven't received the hospital global budget methodology yet. We just want to see does global budgeting work compared to today's or fee for service or the Medicare Shared Savings Program? We want to do a little bit of analysis there, and we just don't have the information from the feds yet, which is an issue. The state global budget methodology needs to be to CMS on June 30th, which is incredibly soon for figuring out how you're going to set hospital global budgets. This is if you didn't get a chance to see the Green Mountain Care Board's presentation from Oliver Wyman on Wednesday. This is from Oliver Wyman through the Act 167 process, and it was recommendations or conditions necessary for succeeding, and I think that word is in something about like population health or value-based care. I don't know why it's all smushed together like that.
That's what it is?
But we can just leave it at conditions necessary for succeeding, so I'm happy with that. And you'll see here that they're looking for alignment of financial incentives, sharing information, adequate resources for primary care, which I think we're all committed to, but also for mental health and preventive services, availability of specialists and diagnostic tests, and of most important to us is availability of appropriate levels of care other than acute inpatient beds, because that's where we're seeing the crunch right now. And that includes mental health beds and extended or long-term care facilities. And then ability of tertiary and other referral facilities to accept patient transfers, and availability of appropriate transportation for patients between facilities. I know you have the EMS report this afternoon. We are very supportive of reforming and helping EMS. There are some really good things in that bill, and we are very much in support of that. EMS, we haven't talked about transportation a lot, but it has been an issue in terms of patients waiting for care, having an inability to communicate with various ambulances, so that if an ambulance is passing by a hospital on the way back, they could pick up a patient that's on the way. We've seen where they've had to go to a hospital, drop a patient off, go all the way back, and then learn that there was a hospital on the way that needed to take a patient somewhere that they could have stopped at. So EMS is crucial to us, and we just support strengthening them as much as possible. So we're talking about healthcare reform and what we need for success. I do want to talk about the role of the Green Mountain Care Board, because I do think regulation is critical as we move forward. And as the Green Mountain Care Board pointed out in their presentation, here's their role. They do play a very big part in regulation and in the success of healthcare reform, and they do health insurer rate review, certificate of need, hospital budgets, ACO oversight and certification, and Medicare total cost of care. And we think that they should continue with that work. We think we do need regulation where we know how Vermont works. Regulation's not going anywhere, and we do think that regulation is necessary to succeed going forward in any healthcare reform efforts. So as we move forward in this discussion, we're just looking for principles for regulation and following those principles. And big things that we see for regulation are role clarity, predictability, and stakeholder input. So on the role clarity piece, it's been a little bit of a struggle in the Act 167 process, and as we move into this global budgets, of just understanding who is doing what and what goes where. So, and that's not to say, Robin and Pat, they work great together. I think people work well together. It's just a matter of, it would be helpful for us to know who is doing what in all of this. And I think that goes for broader healthcare reform. I think that goes for quality. I think that goes for data and other areas as well. So we asked for role clarity in this, and the concept that we want to introduce is you know, the Department of, or the Public Utility Commission is the regulator when we think about utilities. And Act 48 was, setting up the Green Mountain Care Board was based on utilities regulation. They are the ones who do regulation. And then you have the department, which does policy and other efforts. And they're under the executive branch. And so we want an independent, strong regulator, and we think that that is the Green Mountain Care Board. But the Green Mountain Care Board has been tasked with a lot, including with like the health of all Vermonters, which I think that's a really tough task to fill, and I think it makes sense to really define the regulatory role of the Green Mountain Care Board. They also have things like workforce, they have things like prior authorizations, and those areas we're having much more success in those areas through the legislative space than with the Green Mountain Care Board. We know that there's a workforce position over at AHS. They have taken over the strategic planning for workforce, and we think that that role should be there. When you look at quality, you have the Vermont Program for Quality in Healthcare. They're an organization that's in statute. They do a lot of quality work. We think it makes sense for them to continue to do the quality work and not have another organization doing different quality metrics and having to answer to both. So we're looking to streamline things, clarify the roles, and really have a clear definition of what regulation looks like versus what policy looks like going into all of the work that's happening around global budgets and what we're going to have to see in the next couple of years. We also look for predictability, and we want to ensure that there's understanding of how the process is going to work and that the process doesn't change midstream. Again, we're fragile all around, and so the more predictability we have, the more successful we can be in this. And then an opportunity for stakeholder input as well. We think that's really important. A lot of smart people work over at the Green Mountain Care Board. There are a lot of smart people at AHS. But again, like that on the ground perspective there needs to be a pathway for that on the ground perspective also in all of this.
Can I ask a question
Yeah.
before we move on? So when you talk about predictability, you're speaking specifically around what I'm trying to say is regulation to me is by its nature kind of unpredictable, but you want a process that's predictable?
Yes.
Okay.
Yeah. I mean, we're not asking for yes.
Okay.
So we want a process that's predictable. We want measurements that are predictable, like give us the North Star that we're trying to reach and don't have that change midway through. Yes.
So do we have a plan? I mean, who's in charge of setting up that plan, with the vision and the strategic plan to get there?
So, can I answer that?
Yeah.
Sure.
Yeah, Senator, that's why we're here.
Okay,
Yeah.
And so that's why we're bringing a diverse group of folks in who have
okay.
significant involvement, and then we might ask them to help us out. So this is where we're headed.
Yeah, I think.
Good question.
Yeah, and so what we would ask for through healthcare, just based on these principles, are clear definition of roles without duplication of efforts. Again, like both to ensure that things run smoothly on the government side and also on the healthcare side. We're really trying to decrease our administrative costs. So not having to report quality to a couple of different places. Administrative alignment, again, plays into, we really want to streamline our work. And so let's align quality data, things like credentialing, enrollment to Medicare. If Medicare is doing this, then I don't see why we need to have several other different standards or methods of collection or that sort of thing. I think alignment could be really helpful in this space. Stakeholder representation in the global budget setting process. So Maryland, Pennsylvania, other countries, when they're setting up global budgets, they have systems that allow for input from all the players. So the hospitals, the payers, consumers. So we would just want to make sure that there's a process for that for global budget setting. And I know people are going to say, we don't even know if we're doing global budgets. And again, this is a chicken or egg thing, right? Like, we don't know if we're doing global budgets, and we actually can't make a decision if we don't know what the process is going to look like either. So there's that, and then payment model governance and fee-for-service regulation. This is just me saying we also have to look at global hospital budgets and what does that look like? Right now, we have hospitals that set their budgets, and then the Green Mountain Care Board comes in and checks that out and adjusts as necessary. With global budgets, it's gonna be someone else setting the global budget. And then do you have that person come in and determine, like, how does that work? What does that look like? Should we be looking at the whole model? How are we going to set up the system for the whole model? One thing I think with the all-payer model is it felt like we looked at little pieces and we never got a chance to really look at the whole scope of the model and if we were reaching our statewide goals and what we needed to do to reach our statewide goals. So that's another piece I'd like to see as well. And that is all I have.
Thank you. It's a lot.
Thank you.
But it does inform us in areas that are critically important for decision-making and setting the plan and the vision. Thank you.
So I have a simple mind, and,
No.
and I'm older than anybody else in here, but we used to have 2 old folks' homes in my town when I grew up in the 60s and 70s. And they went out of business because they became over-regulated.
Mm-hmm.
They couldn't keep up with requirements for Americans with Disabilities Act and the people that own them. The buildings are still there.
Mm-hmm.
So it sounds like we got too many hospitals. So obviously.
No, that's not my
No, but
message.
that's what some people think. So,
Yeah.
So it must be profitable. Maybe, and what we have now is a capacity problem. Why don't we go back to the communities and build something to, most of the people that were in those old folks' homes were veterans and were disabled, whatever, but they had families in those communities and people to take care of.
So you've made a statement.
I have.
So we're trying to avoid statements at
Okay,
this
I'm
time
sorry.
until we get into,
Okay.
heard all of the
Okay.
testimony.
I'm thinking out loud.
I know you are.
I
Too
do
much
just
wine. No, so this is good, Senator.
I do just want to say, I do think it's telling that the issues we're dealing with are mental health and long-term care, and those are areas that are traditionally underfunded and have been underfunded for a very, very long time. And now we are seeing that in our hospitals, and it is also driving up costs. So I think, cutting costs is great, but there's a point where it starts to get expensive again because you no longer have the resources to adequately deal with the issue.
Thank you. You're welcome.
Any other questions?
No, that was clear. Thank you very much. So I'm going to suggest that we move on and hear from, Sarah, are you on a timeline? I think I'd like to bring the board up if you would like to do that. When you're here, and Elena, you're here, and then we're going to move on to Pat Jones after that, and then Sarah and Michael.
And I have to step out in 5 minutes, unfortunately.
Yeah.
Do you want me to sit at the table?
Yes, bring your chair up if you want to if you want to sit together, that's absolutely fine. Get organized a little bit. Good morning. So, welcome, and why don't you please introduce yourselves for the record, and then we've asked for some comments, particularly around F211, but we know it's a big discussion.
Sure. So I'd like to thank the chair and the committee for taking time to hear from the care board today and a wide variety of voices. My name is Owen Foster. I think I've met all of you at this point. I'm the chair of the Green Mountain Care Board.
I'm Elena Barabee. I'm the Director of Health Systems Finance.
Who else to just
Your
share some
testimony.
thoughts?
Do we have something in writing from you? And if not, it would be great to have your testimony in writing when we're finished.
Sure. So we've reviewed the bill. There's fairly large structural changes in terms of how we regulate and think about policy and regulation in this state. They're rather sweeping changes that make really fundamental structural changes to how we do things. One of the most important that jumped out to me was that some of the Green Mountain Care Board's work in its regulatory role would be done in collaboration with the administration. This is a pretty large wholesale change. Historically, the Care Board has been treated independently without influence from the administration. And in my experience with Care Board, that's been really a rigid, bright line, very carefully followed rule. And I think a good one. So I do not know where the administration stands on any decisions that the Care Board has made since I've been there. They do not suggest what we should do, and they do not tell us if they like it or don't like it. And I think in the healthcare space,
I'm going to ask a question about where you see that. I'm going to start in section 1, and it talks about healthcare reform and improving quality and affordability. So one of the conversations that I think we'd like to have around the board and its role is its role in directing and planning healthcare reform versus regulation. And so having some cooperative support or work with AHS in the reform planning part is different from regulation. So just your thinking on that as a board and where you currently are and how the collaboration might change the reform planning process.
right, so to answer the first question, what I was addressing was section 9375B and the addition there, which is section 5 in this bill,
Okay, good. Thanks.
on page 7.
That's helpful. Thank you.
It states the board shall have the following duties, and then there's language added that says in collaboration with the Director of Healthcare Reform in AHS. So historically, our duties have been done independently, not in collaboration with AHS.
Got it.
This adds that layer of collaboration, which operationally speaking is challenging. Our decisions and our work is really complex. If you look at any hospital submission or rate review submission that we get, then there's huge binders, massive amounts of data. And we have months of work working with our team, educating us, informing us on what it all means. So to add collaboration with AHS means at some level, they're going to have to be taking on the review of all of that. They're going to have to come to the meetings with staff to be educated. They're going to have to come to the hearings and hear the testimony. They're going to have to ask questions. And I don't really know if it means that they have an advisory role. Do they tell us, hey, the administration, Owen, thinks you should give X hospital this much and Y hospital this much. So it injects a political element to it as well that historically the state has felt was preferable not to have there. So there's an operational change, which I think we need to think about. That's a positive or benefit. I think there are positives. I think there are downsides as well. And I think to your second question, the other piece of this I would say is that to me, a little bit confuses roles. So we're responsible for regulating. And now it's a little unclear who's accountable. Are we accountable or is AHS accountable? And are we accountable together? Are we pointing fingers at each other? And when I was at DOJ, we had administration changes. I came in under Obama, and then we had Trump, and we had Biden, and we don't know who we have next. But every time we changed, what we were focused on changed with it, right? So under Obama, we were looking hard at healthcare fraud issues. Then under Trump, immigration became more of a focus, and guns and drugs, and then it switched back. And so having this administration change is less long-term, right? We're long-term, we're 6 years. The Secretary of Administration position is hard, it changes over frequently. So that will change the direction and it will make it a little bit more difficult to have a long-term view, which we think is really critical to healthcare. Right now, we have a massive problem with the community providers. The mental health, the long-term care, the primary care, those problems are real. And if we aren't focused on that solution, I think Ms. Green was speaking about the problems that that has on hospital sustainability. And so we need a long-term plan on that and not jumping around from the next shiny object. We need to think long-term. So I think that this changes that a little bit. Some could say having a politically responsible party involved would be better, right? They're responsible to the people. But it's a big change. I think one that should be considered very, very carefully. I think, Senator Lyons, to your second question about the policy piece, I've struggled with this since I applied for this job. I think one of the first questions I had is policy versus regulation. What do you think? And I never have known what that means, to be honest. Where does it start? Where does it stop? What is policy? When we decide that community providers need more money because they're being gutted right before our eyes, that's policy. There's a policy decision to try and drive money to preventative care. That's policy. If you're negotiating ahead in global budgets, that's policy, right? Great review. If you want to make healthcare more affordable for Vermonters, that's policy, right? So where does it start and stop has always been confusing to me.
So for us, it's legislation is written and then authority is given, and then some of the things that you're talking about are things that you do. That's important to us, so, yeah.
So the best structure that I have come to, in my mind, to handle this is what we've done, the legislature did with Act 167. I do think that you need separation of authorities, right? I do not think it's beneficial. So what we want to do, if you're going to change the legislation, you want it to be durable. You want it to last. You want it to be personality agnostic. You do not want it to matter if it's me as the chair or Elena or Secretary Samuelson or whoever. It needs to be indifferent to who the personalities are. And so from that perspective, policymakers, I'm not talking about anyone currently, but like a policymaker, you can see a situation where they don't want their policy to look bad. So they don't want to evaluate it rigorously. I do not think it's beneficial for the state of Vermont to have policy and evaluation in the exact same place. This bill, I think, puts policy and evaluation together. So I would think about whether or not that's the most advantageous way to structure that component to it. In terms of regulation versus policy, what I would say is how 167 is set up, we have the transparency that the board brings to the table, right? So right now, AHS leads and we collaborate. We have information on hospital sustainability, we have information on healthcare costs, we share that information. We work extremely well together. We work together every single day and it works really, really well. And what we do is if it's just AHS doing policy, there are no board hearings. There is no opportunity for the public to watch a deliberation on what it looks like. And I think that generally that's more favorable for the state of Vermont, to have that public process, to have that. When we have care board hearings, some of the best comments I hear are when we take public comment. That doesn't happen in just a purely administrative state. So here it's clear, it's AHS's lead, it's AHS's negotiation, and we have that level of transparency and also rigor. We evaluate it, we ask hard questions, and that makes it for a better policy. You want the policies rigorously tested and evaluated before you go ahead with them. So my view is the best we can do is probably how we structured 167. And I've been speaking the whole time, and Ms. Barabee may have other thoughts.
No, I think the other thing that I wanted to say in this regard is really thinking, there are role clarity in how we move forward in this policy, this gray area. And I think part of it too is the roles of the board's role in ensuring that wherever we end up in payment and delivery system reform continues to allow us to regulate in the interest of Vermonters. So when we say, that regulatory structures may evolve, maybe the technical way that we implement our budget review process will evolve, but we're still regulating for affordability. We're still regulating for access. We're still evaluating how care looks across the system. And we need to be able to have that system-wide view in order to do that. So I don't think those things would change. I think that actually we're evolving our process and our capabilities to do that work better, and we should keep doing that. And that part won't change as we move from one kind of payment model to another. The technical aspect, it's really important to understand how payment works with regulation to know if there are connections there, right? I think we've been talking about payment as a way to enforce some of the board's budget decisions, but depending on how that local budget is set up, we'll determine what we can do with that.
So, and then along those lines, when you're talking about policies on payment reform, and how do you ensure alignment between different structured, different organizations and payers within the regulatory environment?
Right, so one of the pieces in this bill, something to consider for pros and cons, is that some of the data, I think the data would be chosen by AHS on which the care board would regulate. And then some of the other quality data would be somewhere else. That's not really aligned if you're regulating, I don't know if you guys are football fans, I think it's built for.
Well, but if you put all the data, let's put the VQers and VQHD, and we have all the data, clinical claims data in one place, or in the Department of Health where they are used to looking at population-based improvements. If you have that data and then the board has access to it, but the Department of Health that is used to putting data together can help with that packaging and evaluation. That's kind of what I think is in there.
I think, Madam Chair, that part of regulation is evaluation.
Absolutely.
And if they are relying on AHS to evaluate the data, then that's AHS doing a regulatory role. And I think that's
So the question
that's
is,
what you need separate in order to
what's
have
the
a
best way
fair
to do
regulation.
it? That is the question, and that's what we're asking for a conversation here, right? Thank you.
So my view would be that if you fragment the information, it's not aligned. So if you take the data and put it somewhere else, then you're not in control of the data. You don't know what the data is. You don't understand the data, and then you're making decisions that are hugely consequential for sustainability for everybody. And you don't know the data, right? That's a very concerning thing. It is the saying, if you want me to cook the dinner, I got to be able to pick the groceries. And so, understanding the data is really critical to being able to use it. Data's hard. And we have a really good data team, and having that resource, I think, the other thing is a timing thing, right? So if we don't control the data that we're using to evaluate and regulate, this stuff happens daily, right? The hospital will say, that data's not right, we disagree, here's 45 different things that we want to change about that data. And we have 2.5 months to make 14 hospital budget decisions worth $3.5 billion. We can't rely on some independent private company or third party to then manipulate that data for us in ways that we don't know and then trust the data. So I think the way we do it now is really helpful, that we have a control over the data that we're deciding. It allows us to be very nimble when the hospitals have concerns about the data. And that happened this year, right? This is the first year we moved to a very data-informed, data-driven decision-making process. And we had to deal with it all night at times. And we can't call another agency or a private party and say, hey, can you guys work till 3 in the morning? We need this tomorrow morning. It doesn't happen. So I think that having it not fragmented and aligned is probably a preferable course in my view.
So, but if it's collected in one place and you have access to it, you still can do the evaluation. And then it's also available for other folks to do evaluation from their perspective.
Yeah, and right now we have the data, and other people can, I don't know how many people are in our database, but quite a few get access. We have a data governance council, and they do that. The concern is whether or not what they put in the data, the quality of the data. I don't want to rely on our regulatory decisions on somebody else's manipulation and use of the data and what they choose to get for data.
That's understood.
Yeah.
Yeah, I think the other question too is if we're kind of codifying the role and how we regulate, being not overly prescriptive in the level of detail at which we regulate. So there's some language in here that suggests we shouldn't, for example, regulate at the cost center level, which what a cost center is can also be debated and is confusing, but that wouldn't allow us to direct primary care payments through hospitals. That wouldn't allow us to ask about, set targets for inpatient versus outpatient spending and expenditures. And that it would just kind of really throw a wrench. So I think we need to talk about intent of regulation and then kind of let the rulemaking process kind of specify the technical implementation. But I think that would be also a constructive conversation.
Okay, good.
There's one point that Ms. Green made that I thought was a really good one and I agreed with, which is the stakeholder input in our processes. I think that's really important, and like this committee and what you're doing here, having a broad array of voices is important. And so our stakeholder process needs to be as broad as possible. So when we develop guidance, the hospitals are involved in it. They help review and give us thoughts on, that's happening now, I think. So then they get predictability because the guidance says, here's your target. Your target's 8.6%, it's based on this is why we're doing this. So they have months in advance to be predictable, and they're involved in that development. On the benchmarks and the data that we did this last year, there's the same thing. There's a lot of back and forth for months on what the benchmarks are going to be, what the data will be. I think that point is really, everyone should know what the rules are and what we're shooting for. And that's why we have this guidance process that's developed in conjunction with the association of hospitals.
And I think we should be clear that there's always learning that happens along the way. So we may set a target, but we don't have perfect information to know how budgets are constructed, what assumptions are in there, what assumptions are being, are not included in the budget. So for example, we learned that there, weren't some rate increases that were included in a budget, and then we have to go back and think, well, what does this mean for the broader decision-making and the targets that we set? Does it still meet the target if we know that they left some information out? So I think, we can do all we can to set a process and set targets, but we also need to leave room to learn and to evolve, and our process may need to evolve over time as that learning occurs.
And if the evolution is something that makes change during the budget process, that can make it difficult regardless of who's on the other side of the table and for you. So having some consideration of what that process is to make it as predictable as possible, knowing that there are always problems.
Yeah, in this year, we went way above our guidance. It was supposed to be 8.6 for 2 years.
Yeah.
And we were well above that. And I think that's the flexibility that we spoke about.
Sure.
We got a lot of information from the hospitals. We realized we have huge access problems. And so we went way above our guidance this year.
Yeah.
And I think it was the right decision. One other point that jumped out that I thought would be worth discussion is there's a provision about fixed prospective payments not being regulated by the care board. So in terms of alignment, not fragmenting the system too much, you want everything kind of where it should be. You would have two different structures for developing budgets. You'd have one structure at the Green Mountain Care Board and one that's not. And so you also get some conflict, right? So if AHS is collaborating or setting a global budget, they're a payer, right? So they might have a different interest than an insurance company or Medicare. So if you fragment it and move it over here and one piece here, it does get more confusing, I think, in the administrative costs of the hospital.
How would you fix that? I mean, that is a huge problem.
I think that one entity does hospital budgets.
Which entity? I mean, I won't put you on the spot at this point, but it would be helpful to have the entities in the room get together and discuss that, because that having alignment between private, public, and then and our regulatory entities, having that solidified would be great.
Yeah, I think historically it's always been the Green Mountain Care Board.
Yes.
We have the infrastructure, the team to do it. So I think it makes sense for the care board to develop budgets.
Right. Well, and the alignment of fixed prospective payments.
So when I read that language, to me, it sounded like we're delivering a check and then there's no oversight. So I mean, I think being clear about what it is we're trying to do and what we're regulating and monitoring for is the question.
So if you think about the local budgets, sorry, did I interrupt?
No, go ahead, you go ahead.
There's the money, right? But then beyond that, there's going to be adjustments, population adjustments, utilization adjustments, potentially quality adjustments, access adjustments, provider, whatever they might be. Somebody has to make those decisions. as to what the adjustment should be. I think if you have the information from one process on utilization and quality or whatever it might be, you don't want AHS doing that piece and somebody else doing it for the rest of it. Because keep in mind, even under the best case scenario, if we go over budgets, it's still going to be a huge amount of it would be in fee for service. So having two different set, you know what I mean? You're duplicating the work in a way. And I think it's probably harder for hospitals to deal with two entities on the same type of topic.
Or just think about an independent provider.
Right.
There's 16 different.
So Madam Chair, I mean, fixed prospective payments are part of the budget. They are,
Yes, I
they are
understand.
part of the revenue of a
I
budget.
understand.
So having them separated out from the rest of the budget does
I
not make
understand.
sense.
No, this is language that was put in on request, and this is an important conversation.
Yeah, our view would be to be better for one entity for simplicity's sake.
Yeah. Thank you. Okay. Let's keep them.
Keep going. Okay.
We're getting the board's perspective. This is
Yeah.
terrific. Yeah.
We didn't get to have this kind of conversation with the hospital association. You asked us not to ask questions, so
No, but I'm trying to make sure that we understand, because the hospital did not go through the bill specifically. I want to make sure that we know where we are and that these are sections of the bill. That's it.
So there's two provisions in here that I think are also very important to think about for the legislators to consider, and that is the provisions about equitable reimbursement and sort of the system-wide view that this adds to the Green Mountain Care Board's regulatory function.
which page and sections, please?
Section page 12.
We're talking about equitable reimbursement.
Yes, I think
Yeah.
it's section 12. One second.
No, it's page 12.
Section 12 starts on page 21, budget review,
It's there.
9456.
Well, there's a section on page 5, aligning payer policies, administrative obligations, clinical services, to reduce administrative burdens, establish and improve equitable reimbursements, and ensure clinically appropriate care coordination and continuity of an access to high quality care.
So I think it's in
So
two.
the sort of the charge, overall charge. That's on page 5.
And page 13.
Page 13,
And also 22. So why don't we,
22, okay,
why
so,
don't we take them piece by piece?
oh yeah.
13.
Yes, number 4 on page 22.
Correct. Okay. So let's start on page 13, section 6 of the bill. And it's B1B, and the language added is the board may utilize reference-based pricing, site-neutral payments, and other strategies that promote equitable reimbursement and the quality of access to and affordability of healthcare services in the state, provided such strategies are not inconsistent with the state's healthcare reform initiatives. And then on 22, somewhat related language, 22, page 22. Section 4. Consider the expenditure analysis for the previous year and the proposed expenditure analysis for the year under review, as well as evaluating and considering spending across sectors of the healthcare industry, including primary care, mental health, long-term care, hospitals, independent specialists, and substance use disorder treatment. So I think a lot of the conversation lately has been around the insufficient levels of mental health, long-term care, and primary care that we have in the state. I think that's the right conversation to have. So if hospitals are going to be sustainable and we're going to have good health care, we're going to have to fix those. So the care board's purview is really hospitals, and so making sure that the care board, when we make our decisions, are considering what's happening in the broader healthcare system, I think is really, really important. And that's one of the things we did this last year in our rate review, is we said insurance companies need to consider when they're awarding rates, how all these are doing. Because if these aren't sustainable, hospitals are not sustainable, and people are sicker. So that's really critical.
That's the alignment that is critical. I mean, absolutely.
So just to be clear, alignment's been used in so many different ways in this conversation, and it's confusing when you keep saying that, but, so on page 13, B, paragraph B, and on page 22, paragraph 4, you are supportive of including that language, or do you think it muddles?
Maybe some tweaking, I'm hearing.
I would be supportive of both. The language on page 13 that you referenced, Senator Hardy. Equitable reimbursement, if you hear from non-hospitals, they're really concerned about their level of reimbursement. That's part of the reason we don't have sufficient mental health care and primary care is their reimbursements are too low. And so in our rate review, we learned this year quite a bit of information about the disparity in the rates that are going to some sectors of the healthcare industry versus the others. And it's been like that for years, and it's having a negative impact on some of the foundations of our healthcare system. So what equitable reimbursement will help us do is make sure that those levels are fair and appropriate. So, you got to think about treating the symptom or the cause, right? So the symptom is all this backs up in the hospitals. It's not their fault. It's not. They don't have long-term care. They don't have primary care. It costs them a lot of money. And so are we going to throw money there, which is needed? They need that money. Or can you put it in where it needs to go so they don't have those problems back up? Now, you can't just flick a switch. You got to do it long-term, right? You got to do it in a balanced and measured way so you don't harm the healthcare system with a big shock. And so I think that equitable reimbursement language helps direct the board to make sure it's more mindful as we go forward in our regulatory processes.
And I do have a question here, and I linked that in with one of your slides that we had when we met together with House Health, and on the difference between reimbursement, let's just leave it at reimbursement for a Copley hospital, which has had difficulty for many years, and other hospitals which are a little bit better. Some are still in the red, but so how do you make that equitable for those critical care hospitals and bring them up to some level?
That's exactly right.
Equity.
That's a really good question. So, right. There are measures to look at how hospitals are being reimbursed and everybody else in the healthcare system. So one of them is reference-based pricing or some multiple of Medicare, right? So some hospitals are around 280, 290, 300% of Medicare. They get 200, 300% of Medicare. Others might be lower, 180% of Medicare. So what our hospital budget process this year was meant to do was consider, where are you starting when you ask for 15%? If you're starting really high, and your expenses are really out of control, should we be giving you that level of increase? Or if you take a Copley, which has been historically quite a bit lower on that scale, and their costs are really low, and their quality is really high, don't we want to put the money there and reward that high performance? And the Care Board's decision this year was, yes, we do. So if you look at what we gave Copley and the rate increase, we gave them an 8% increase. I think it was the largest increase we gave. Was because their costs were generally lower, their quality was high, and their expenses were pretty good. Whereas other hospitals had higher starting points and asked for a lot of money.
And I think if that is the goal, making sure that's consistent throughout this bill is really important, because I think there are a number of areas where there's conflict with that construct. So if we're just giving revenue and not thinking about the underlying expenses, we could be underpaying or we could be overpaying, but we really need to think about the budget together. Similarly, there's a section at the end on population-based payment, which is a little confusing because it's kind of at odds with some of the assumptions of the global payment that is being designed under the AHEAD model. But that too, I think, has some implications for inequities across communities. So it would kind of preference some of the larger communities. It kind of may not make sense from an equitable, access consideration.
Well, we're interested in that perspective, and then how can we build legislation that brings that makes it more equitable. I did not want to use the term alignment, but.
Is this section 15 you're asking, you're
Correct, page
referencing? This
28.
is this report that again has the Agency of Human Services and DFR creating a plan about hospital budgeting, which is in conflict with
Well,
the
some of that is
regulatory
related
process.
to the, what we're doing, moving ahead, and how can we get at equitable reimbursement for, maybe hospital isn't the right word here, but all providers.
I don't understand what you mean by
We'll
that,
get to
because,
that.
well, I keep hearing the same words, but none of them are, they're used in so many different ways that it's not consistent.
Well, the bill is not consistent because it's come from different places. And so we're going to move it in a direction that will be across the board, equitable and understandable, and meet our regulatory needs in the state as well as our delivery needs. So when we talk about that, we haven't gotten to that last study.
So that is really what the care board's been trying to do in the last year is make sure that the hospital's performing well, are given the resources they need to do well, and so that they're able to, and then also being mindful of that system-wide view.
So Mike, I guess, keep going, and because I do have a question for you at the end.
I think just the last thing I would like to say, off the top of my mind, is the resources. There's a lot of work in here, and collaboration adds a whole extra layer, and it's great, and we should do it, and we should, have community input and a lot of voices, but I think there's a lot of new kind of big initiatives here, and I think we just, as we sort out where this bill will go, it'll be important to think about resources.
So if we look at the work that's going on with Act 167, and obviously the assessment of community needs extends into different providers, so community service providers and independent providers, primary care, and so on. And that the hospital transformation will be linked in with those providers. And that's where the collaboration, I know that has been terrific in 167. How can we continue that in further discussions going forward with the head or any other changes that we're seeing in global budgeting? That, I think, is the question. I'll leave it there for you.
Can I ask?
Although I'm asking a question, I want to see what the answer is.
I understand.
Could you give it to me one more time?
We have work going on now that has been quite collaborative with the Agency of Human Services with Act 167, where a consideration for community service needs, independent provider needs, and all of our healthcare services healthcare needs at the local level. It's been put into consideration along with hospitals and what role hospitals can play in that transformation to meet the community needs. So can we continue with that process going forward? So it is a collaborative. It may not be collaborative. It might be reaching out to understand and to work together. It doesn't mean giving up regulatory authority, but it does mean making those regulatory decisions in the broader context.
You see, yes. So there's very lengthy plans out for continued collaboration. We have a number of meetings scheduled and everything else for months for Ms. Jones, who asked to come and testify with us. And so I think the plan is to continue the 167 work. We will be having a report to the legislature probably this summer. And at that point, that work is done. And the hospitals and local boards will have decisions to make as to what they can do to make the system more effective and efficient, cost efficient. So that work the collaboration will end at that point unless we're directed by the legislature to do something different. And then on the global budgets, we're putting in the NOFO in 2 months. And then we're working on what the global budget design would be. And then we have decision points kind of into the summer. And then even after that, we'll be continuing to work together on the negotiation process.
And to be clear, it's the administration that's putting in the application. The board has been working with the
Right, I
administration to
understand.
create, yes.
So then, so what I would suggest is, we can move on. I know there were a lot of questions around the table. This isn't the last time that you'll be sitting here with us on this bill, however it triggers off. And I would, there's one piece that you didn't address, and that was shifting the budget decision-making for insurance rates versus hospital budget. And can you comment on that? Because I've heard, I think we've talked about this and heard that it might be an improvement to put hospitals first, but I'm open to that.
Yeah, I can briefly address that if you'd like, Chair.
Yeah.
Oh, yeah. Okay, so there's
I know
pros.
it's a complicated thing.
Yeah, there's pros and cons to moving it, right?
Yeah.
One is it will cost hospitals money and resources to shift their calendar to do the budgetary decisions earlier, in June as opposed to when we make the decisions October 1st now, right? So
Yeah.
there's that component to it. I think that it's better in a way that you know what the hospital increases are going to be before you decide your insurance rate increase, right? So the only real big component of what we change in an insurance rate is the hospital costs. There's so many pieces to that insurance increase that we don't touch. Pharmaceutical costs, utilization costs, like those things are baked in there. So there's a big chunk of money going up regardless of what we do. The biggest impact we have is on the hospital regulation piece. So it arguably makes more sense to know what that number is before you go and decide the rate piece. I would say that if we're thinking about affordability, maybe you want rate review first because you think about what can Vermonters afford, and you decide that, and then you've got to decide the hospitals to make sure that it's something you can afford, right? So there's pros and cons to switching. It's a rough summer, I think, for hospitals and the care board, frankly, if we get the budgets June 30th, and it's.
I know, I look at that date.
Decisions are done by September 15th. We have 14 hearings. We have lots of back and forth questions. One of the hearings, I think, was like 12 or 13 hours this year. It's rough on staff. On the resource point that Ms. Barabee made, our hospital budget team is 3.5 people. 14 hospitals, $3.5 billion, 2.5 months, 3.5 people. And we have a lot of burnout. This position that Ms. Barabee holds flips a lot. And I know why. It's really tough to handle all that with such consequential decisions and such stress. You're going to really harm Vermonters' pockets, or you're going to risk harming hospitals or broader people in the healthcare community. That stress is hard. And with the limited resources we have in that time frame with those monumental decisions, it's really tough.
Dale, thank you for your comments. Question.
Thanks. It would be really helpful if you guys could go through the bill and give us a section by section of what your and I know Chair Foster, you've been trying to be diplomatic in a lot of your comments, but I want to know, do you support this? I want the cut and dried, like the Hospital Association gave us, from section by section, and then why. Thank you.
So, and I'm also going to suggest that we've heard we're going to continue to hear comments from people in the room, that there are some changes that do need to be made. I mean, perception out in the Vermont world and by stakeholders, by patients and others who want to be involved. And so there are some changes that would help improve A, the perception, but B, the process. And so we hear that from providers and hospitals overall. So it would be helpful to have that conversation happen outside of this committee so that we can get to some level of understanding and agreement between and among the folks who are so concerned about what's happening right now. We do not want to undermine the regulatory strength of the board, and I want to say that very clearly. But we would like to know that administrative burden can be reduced by bringing things together. And we do want to know that costs can be reduced. And we do want to know that there is data available for quality improvement regardless of the payer. So, and that'll be then a conversation that we'll have with Blue Cross and Blue Shield. How can we merge some of the population that's not currently included within that clinical or claims data? So there are a lot of little things that might add up to overall improvement. If they can happen, that would be wonderful. And you guys are terrific, and I appreciate the time that you've taken both to look at this bill, but also to come in and put yourselves in front of us. Appreciate that.
Thank you very much for hearing from us. These are really important discussions, so thanks for doing this.
Yeah, of course.
Thank you.
Can't do it without you. Pat, I'm gonna bring you up, and then Sarah, you're okay?
Fine.
All right, good. Glad you're here. Wait, you know what? Before we go ahead, sorry.
I
Totally.
four
Let's-
words a lot.
Would you mind if we took a little break? No. I think the committee needs a brain break.
Thank you.
So let's take up until 20 of. Are you good with your time?
I'm good with my time.
All right, thanks. All right, we'll take